Good evening, dear colleagues. I'm very pleased to welcome you to this webinar organized by the Special Interest Group on Continence of the European Association of Urology Nurses. Today, we will talk about neuromodulation for refractory pelvic pain with nursing implication, anatomy, physiology, patient assessment, and evidence-based practice. I am very pleased to introduce the faculty. We will have Dr. Maria Chiara Sighinolfi. She's a urologist. She is from Italy. She works in a major university hospital in Milan. And we will also have Dr. Diane Newman. She is a nurse, a PhD, and a very experienced colleague in pelvic floor rehabilitation, pelvic pain, neuromodulation. She's also among the authors of the SUNA core curriculum for urology nursing, which is a very valuable textbook that we all know and appreciate. So among the objectives of this course, there is, first of all, to find out some relevant information about pathophysiology of chronic pelvic pain and why pelvic pain can become refractory. And then we will say something about the various types of neuromodulation, their rationale, their anatomical and physiological rationale, their nursing implication. And finally, we will go through patient assessment and what is important to establish a proper assessment and rehabilitation plan, and also to establish a proper therapeutic relationship with the patient. So it is my pleasure to leave the word to Dr. Sighinolfi for her introductory speech on pathophysiology and anatomy of the structures involved in the development of chronic pelvic pain. Please, Maria Chiara.
Thank you, Stefano, and thank you for this invitation. So what is pain? Pain in general is defined as an unpleasant sensory and emotional experience that is associated with actual or potential tissue damage, or is described in terms of such damage. So chronic pain is defined as a pain that persists or recurs for longer than 3 months, and it has been recently included into the ICD classification, that is the International Classification of Diseases. And it has been divided into a chronic primary pain that is multifactorial. It includes biological, psychological, and social factors that all contribute to the pain syndrome. And the chronic secondary pain conditions that are related, and they are consequences to cancer, post-surgical, to pathological conditions. Pelvic pain is a main issue for patients and for healthcare systems because in a woman it is a very common and debilitating complaint. The prevalence of chronic pelvic pain in females is ranging from 4 to 15%, and it accounts for 10% of all ambulatory referrals to gynecologists and represents the indication for 12% of hysterectomies and for over 40% of diagnostic laparoscopies. But also for us as urologists, it is quite a frequent problem because in men, the prevalence of chronic pelvic pain is ranging from 4 to 11%, and it accounts for 8% of urological consultation. And this pain, the chronic pelvic pain, is not only significantly deteriorating the quality of life of the patients, but also is affecting the relationships with the partners, colleagues, relatives. And do not forget that it is very frustrating for physicians and therapists too, because we try to identify the pathological reason to justify this clinical condition. But the physician is not able to diagnose the source of the complaints in up to 33% of the cases. And in the absence of a conclusive diagnosis, the patients are commonly and erroneously defined as psychogenic cause of their pain. And this fact further increases the patient's disappointment. So how is defined the chronic pelvic pain syndrome by EAU? It is defined as the occurrence of chronic pain when there is no proven infection or other obvious local pathology that may account for that pain. And it is often associated with negative cognitive, behavioral, sexual, or emotional consequences, and also with symptoms suggestive, for example, of lower urinary tract symptoms, but also sexual symptoms, bowel, or gynecological dysfunction. The pain syndromes are defined by a process of exclusion. So we think about what we are searching for, what are we leaving, what's left in the complaints, in the diagnostic pathway of the patients. But finally, there should be no evidence of ongoing infection or inflammation. And investigation by end organ specialists should therefore be aimed at obtaining a differential diagnosis. But physicians finally should be aware that repeated and unnecessary investigation are detrimental for the patients and for the management of the disease. This is the EAU classification of chronic pelvic pain syndrome. What characterizes this kind of pain? There are some features that characterizes this pain. So the system that can be urological, gynecological, gastrointestinal, and so on. The end organ of pain, the referral characteristics of this kind of pain, different temporal characteristics. For example, chronic pelvic pain syndrome can, the onset of this pain could be acute or it could be chronic. It can be sporadic, cyclical, or continuous, so that temporal characteristics. And it can be itching, burning, stabbing, or electric kind of be felt as in this kind of ways. And as previously said, it can be associated to other symptoms that could be urological, so frequency, nocturia, hesitancy, and urgency, gynecological symptoms related to menstrual or menopause symptoms, gastrointestinal symptoms such as constipation or diarrhea. And finally, it could be also psychological symptoms could be involved, symptoms of anxiety and depression. So these are the characteristics that describe the features of the possible features of chronic pelvic pain syndromes. But let's go back to the nerve, to the innervation of the pelvis. The anatomical structures that may give rise to the pain in the pelvic region belong to the urinary, reproductive, and gastrointestinal systems. These structures create a complex anatomical and neurobiological network. So we have a visceral efferents that travel the sympathetic trunk that have cell bodies in the thoracolumbar dorsal root ganglia, and other efferents that travel with the parasympathetic fibers that have cell bodies in the sacral root ganglia. The hypogastric plexus is the main autonomic neuronal center of the pelvis, whereas the pudendal nerve guarantees the somatic innervation. The pudendal nerve, we know, is the main nerve of the pelvis, involved in a great amount of pelvic conditions. This picture represents the female pelvic anatomy. So we can have a sensory axons that innervates the vagina, but also the clitoris and the anus that reach the spinal cord via pelvic nerves and terminate in the sacral spinal cord segments. And then we have axons innervating the uterus that, but not only the uterus, also the bladder, for example, that travel in the hypogastric nerves and terminates in the thoracolumbar spinal cord segments. The region surrounding the cervix represents a transitional zone that can be innervated by both pathways. And the male anatomy, the similar nerve anatomy with the pudendal nerve and the hypogastric plexus as well. There are different characteristics of visceral and somatic pain. Visceral pain, we know that is poorly localized. It is felt as a stretching and distension. The presence of autonomic features such as nausea and sweating may occur. Muscle hyperalgesia is common in the visceral pain, and pain can be perceived also at a site distant to the cause of pain. Whereas somatic pain is different. It is well localized pain from mechanical, thermal, chemical, and electrical stimuli. And autonomic features are less frequent. Hyperalgesia is well localized, so that there are different characteristics of these two kinds of pain. And cross-system mechanism and visual interactions where can be present too in the chronic pelvic pain syndrome, because gastrointestinal, urinary, and reproductive systems converge sensory information via both the peripheral and central mechanism of stimulus processing, so that there are visual interactions. For example, colon and uterine inflammation may produce a sign of inflammation to the bladder because the effect of the hypogastric nerve, whereas endometriosis not only produces vaginal symptoms, but can also exacerbate renal colic-like pain, so that pathology occurring inside an organ may have significant effects on other healthy organs. So let's see the very basis of the mechanism of chronic pelvic pain syndrome. All the structure within the pelvis and also some outside the pelvis may result when stimulating to pain perceived in the pelvis. And the recurrent activation of the nervous system may be associated with both peripheral and then central sensitization. So a lower threshold activation of the peripheral nociceptors with increased pain perception may occur, and with an increased receptive field as well. So patients become aware of stimuli that are not normally perceived, and this phenomenon is called hyperesthesia. And stimuli that are normally not painful become perceived as painful. This phenomenon is called Alodonia. Finally, we can have also, as we have said, a crossover hypersensitivity occurrence, visceral interactions. And final, a central sensitization with mediated functional abnormalities of the viscera or changes in the peripheral structures. And everything finally ends up with the neurobiological and psychological consequences as well. So everything starts from the peripheral nociceptors activation, because we have said that in chronic pelvic pain, an ongoing tissue trauma, inflammation, or infection is absent. An acute process is absent, but conditions that produce recurrent trauma, infection, or inflammation may finally result in a chronic pelvic pain syndrome. For example, as a urologist, we can say that among patients with acute bacterial prostatitis, 10% and may end up with a chronic pain syndrome. And so the early stages of assessment should include looking for these pathologies, for these previous pathologies, but once excluded an acute phenomenon, persisting investigation for these causes are rarely helpful and may improve the frustration and can be detrimental for the patients. When an acute pain mechanism are activated by nociceptive events, sensitization of those transducers may also occur. Therefore, the signaling can be magnified, and the afferents that are not normally active may be activated by this change. The increased afferent signaling can be a trigger for the chronic pain mechanism that maintain the perception of pain in absence of an ongoing and acute peripheral pathology, so that peripheral sensitization is starting the process. And the mechanism by which the peripheral transducer may exhibit an increase in sensibility are different. We can have a modification of the peripheral tissue, which may result in the transducers being more exposed to a peripheral stimulation. Then there may be an increase in the chemicals that stimulate the receptors of the transducer, nerve growth factor induced hypersensitivity, or an increase in ATP release with a noxious stimuli. And there are many modifications in the receptor that results in them being more sensitive, and after that, lower threshold and increase peripheral responsiveness. That may translate into central sensitization, because nociception is the process of transmitting information to centers involved in perception of a stimulus that has the potential to cause the tissue damage. But pain is a more complex process, and it involves the activation of the nociceptive pathway, but also an emotional response, so that the brain may affect the modulation of pain pathways at the spinal cord level. And the neuronal sensitization is responsible for a decrease in threshold and an increase in response duration and magnification. As a result, the sensitization amplifies what we perceived from a peripheral stimulus. For example, a cutaneous stimulus that, such as a light touch, normally does not produce pain, but when the central sensitization is present, a light touch may be perceived as painful, the phenomenon of Alodonia. And the non-noxious stimuli may finally be interpreted as pain, and the stimuli that are normally noxious may be magnified with an increased perception of pain. This is the mechanism that finally may transduce into a psychological mechanism, psychological consequences, because of various psychological processes affect pain modulation at a higher level. And inhibiting or facilitating the strength of the nociceptive signal reaching the consciousness and appraisal and interpretation of that signal will also modulate the response to the nociceptive message and the pain experience. So the involvement of a higher central learning may occur at both a conscious and subconscious level. And all of this results into chronic primary pain syndrome, and Dr. Newman will speak about, will give a lecture about this chronic primary pelvic pain syndrome that may involve the urological apparatus, gynecological, they can be gynecological, internal genitalia and external genitalia as well, and gastrointestinal, involve the gastrointestinal system. So in conclusion, the chronic pelvic pain is a main issue for patient, physician, and the healthcare systems. It is defined as no proven infection, without the occurrence of a proven infection or other obvious local pathology. The peripheral nociception can lead to sensitization, amplification, and central sensitization. Cross-system mechanism and the visual interaction may be present. And various psychological mechanisms may affect the pain neuromodulation at a higher level as well. So physician, therapist, finally, should be aware of this mechanism to improve patients' care and the management of this disease. And finally, I would like to quote this paper, the book, and our guidelines, urological guidelines, from which the lecture was made. Thank you.
Thank you very much, Chiara, for the clear explanation and for pointing out the fundamental mechanisms underlying pain and the development of important things that will need to be considered during patient assessment. So what can we do in order to treat these situations which are very disabling for the patients and can deeply affect and impair quality of life? One of the possibilities suggested in the guidelines is neuromodulation, which is the main topic of this webinar. So I am sharing my screen. In this presentation, I would like to highlight the principles of neuromodulation, as well as some practical indications for nursing. In particular, I would also like to provide relevant references with practical information, because a neuromodulation has many parameters, many characteristics, can be done in several ways. So it is impossible to outline all the parameters and the characteristics in a single lecture. That would make no sense. So I'm citing some papers, which I have also sent to the organizers of this course, and you will receive all these papers so that you can go in depth with your convenience. So what is the rationale of neuromodulation? The rationale is that the rationale is that neuromodulation is a family of therapies based on electrical stimulation to target specific nerves that controls LUTs, so lower urinary tract symptoms, and pain, as has been pointed out by Dr. Signolfi a few minutes ago. The aim is to modulate our response, so basically to modulate what happens inside the nervous system in order to obtain some therapeutic effects, such as the reduction of pain or reduction of LUTs. We know that neuromodulation can also be used for overactive bladder, for instance. Neuromodulation includes several ways, can be done in several ways, including pelvic floor electrical stimulation, which we usually see also for strengthening the pelvic floor in case of urinary incontinence. Let's remember that there are two main branches of in pelvic dysfunction. We can have a non-contracting pelvic floor, which will result in urinary incontinence, requiring some electrical parameters, specific electrical parameters, in order to strengthen the muscles and make them contract, and non-relaxing pelvic floor, which is usually the underlying condition of persistent pain. So this will require a separate treatment. So we have sort of a Swiss knife. I mean that by using the same instruments, such as electrical stimulation or magnetic innervation, if we change the parameters of the treatment, we can use the same treatment, the same tool for both non-contracting and non-relaxing pelvic floor. So is neuromodulation a new idea? No, definitely not. In the 60s, the first implementations of neuromodulation were started, and the fundamentals were laid with the gate control theory, which is a fundamental theory underlying the treatment of pain. TENS was introduced between the 60s and the 70s. We will be describing this therapeutic option in a minute. Percutaneous tibial nerve stimulation was introduced by McGuire and then by Stoller also in the early 80s. The first puncture approach for stimulating or blocking the pudendal nerve was described in the late 80s. The use of PTNS, percutaneous tibial nerve stimulation, in chronic pelvic pain was introduced in the early years of this new century, and then it comes to recent story, but that's a long story made short, actually, so it's not a new idea. So there are several types and characteristics of neuromodulation. We can do it in several ways. Each way has its pros and cons, of course. This is a summary table taken from a paper that I invite you to read. This will be sent to you by the organizers. We can do it by pelvic floor electrical stimulation, inferential therapy, the so-called interferential currents, magnetic stimulation, also known as EXMI, extracorporeal magnetic innervation, which has recently been renewed with new machines able to convey and direct the magnetic field, and sacral nerve stimulation, as well as percutaneous tibial nerve stimulation. So let's go quickly through all these options. This is the very well-known probe for electrical stimulation. We usually employ this technique for functional electrical stimulation, meaning that we use it for patients, both male and female, with a non-contracting pelvic floor, which means urinary incontinence. Can it be used for pain as well? Yes, definitely. This is one of the main papers on this topic, on the use of this kind of stimulation for pain. Vaginal diazepam plus transcutaneous electrical nerve stimulation to treat vestibulodynia, a randomized controlled trial. In this paper, actually, the researchers used an intravaginal probe with a standard protocol for TENS, which means a transcutaneous electrical nerve stimulation. With these parameters, I am reporting the parameters not for being technical, but because these are the practical information that we need when we are in the outpatients with our person and we need to apply correctly the treatments. So what were the results? Here we have a visual analog scale, so the pain scores actually, and a statistically significant difference was observed in favor of the treatment, so the combination between diazepam and electrical nerve stimulation in terms of pain reduction. Still from the same study, a statistically significant difference was observed in the capability of the pelvic muscle of the patients undergoing treatment with the neuromodulation to relax. So I said it before, I told it before, the main problem underlying pelvic pain is non-relaxing. So the ability of having a muscle that goes back to the starting point, to the initial muscular tone after contraction, is of paramount importance. So this is an example of how electrical stimulation can be used for antalgic purposes. The TENS was mentioned in the paper I showed before. This is an interesting article. These are all recent papers. There is a very complex mechanism. TENS-induced blockade of afferent input from peripheral neurons. We will see that the impulses generated by the TENS travel in both directions along the axon, and those conducted toward the periphery antagonize the nerve impulses arising from the distal structures. So we have the dashed arrows, and vice versa. Nociceptive input conducted in higher threshold, so the fibers called the A, delta, and C fibers, is more likely to benefit from higher amplitude currents of TENS. We know that the electrical parameters of all these treatments are amplitude of current, different of potential, so microvolts or millivolts, it depends on the treatment, the timing, and also the waveform for some treatments. So this is why the amplitude current is mentioned here. Still about the rationale of the TENS, the amplitude of the currents is regulated to selectively activated low nerve fibers, so the A beta, generating nerve impulses that activate the inhibitory interneurons in the central nervous system. This results in the actual effects of reduced nociception and the antalgic effects that we desire. This slide is a bit technical. It's just to show that several waveforms for the current can be used by the nurse while applying TENS. TENS overall aims to elicit physiological neuromodulation, so the electrical characteristics of the current deeply affect the type of nerve fibers which can benefit and which can be modulated, activated by the treatment itself. So these are some suggestions that you will find described in further detail in this paper. This is true also for electrical stimulation of the pelvic floor as well. Depending on the waveform and the characteristics of the treatment, you make different muscles contract in case of non-contracting pelvic floor. Just a few words about interferential currents. So interferential treatment. This is a coronal view of the human body, of course. This is the spine. And in this paper by the European Association of Urology, this treatment is described in excellent detail. But basically, two different medium frequency currents of around 4,000 hertz, this can be, of course, regulated with the machine, are applied to the body from different directions using 4 surface electrodes. You will see them here. So that sort of a cross of interferential waves can be generated by the crossing of these two currents in the bladder or the pelvic floor. This is another option. Interferential currents are less common than pelvic floor electrical stimulation or PTNS or TTNS, at least here in Italy, but these are described in the literature. As regards their characteristics, a recent review has cited several randomized controlled trials in which some applications have been attempted. For instance, one of them has studied the effectiveness on pelvic pain related to irritable bowel syndrome, IBS. After 4 weeks of 12 sessions of treatment, initially the treatment and placebo group were comparable, but the severity of symptoms continued to decrease only in the interferential current group at 1 month after the treatment, and it went on decreasing over time. So this is a long-lasting effect, which is of particular interest. What about sacral root stimulation? Well, we know that the anatomy of the pelvic floor is strictly related to the sacral roots for the characteristics of the innervation. Here we see in both this drawing and this radiological picture that sacral root stimulation can be done through an implanted device. It's quite common, actually. Usually an initial implant of the electrodes only, without without performing the incision for implanting the whole stimulator is attempted, so that for the first 7 days or 10 days, depending on the centers, the patient can use an external modulator without having an implanted device and see if this treatment works well for them. If the response is positive, then the definitive implant is made in the operating room with 2 electrodes implanted near the sacral root and a subcutaneous pocket which hosts this device. This is a commercial device. I'm not, of course, mentioning the brand. It has the width, the diameter of a coin, a 2 euros coin, of course. So it's about a couple of centimeters, if not less. The recent models are very, very, very small. And there is a wireless external device which allows control. These devices are set by the doctor or the nurse, usually the nurse. And then there is a password, a passcode that only the nurse and the doctor know, so that the patient can only increase or decrease the intensity of the stimulation. What are the drawbacks? Discomfort at the implantation site is the most common adverse event, with additional adverse events included seroma at the implantation site, infection, wire migration, and device malfunction. The question is, this is a surgical option, but this is a course for nurses, and in the learning objectives, we promised that we would discuss the nursing aspect of neuromodulation. So can this treatment be administered transcutaneously? The answer is yes. This is a project that we have presented during the European conference of the EAUN in Amsterdam last July. And our goal was to see if patients could be treated in an outpatient setting, basically without surgery, similarly to what we do with the transcutaneous tibial nerve stimulation and other types of treatment with sticky electrodes, surface electrodes. So the title of the project was Helping Patients with Chronic Pelvic Pain and Non-Relaxing Pelvic Floor, Nurse-Led Transcutaneous Sacral Neuromodulation. These were the positions of the electrodes. So we know that the electrical stimulator has 2 wires, actually. One goes to the patient, the other returns. So it's similar to the electrical plant that we all have in our houses. There is a wire carrying the current and the other one which is neutral. So this results in a flow of current from and to the machine. The research project was aimed at verifying the efficacy of transcutaneous neuromodulation for pelvic floor pain refractory to other treatments, and it was awarded the EAUN Research Prize. The project is ongoing, it has been registered, and if you want further details on the parameters and on the characteristics of our patient and of this ongoing project, we will be more than happy to share our findings with you. Several times in this presentation, I mentioned percutaneous tibial nerve stimulation. This was invented by, actually, it was introduced by Stoller in the 80s, in 83 or so. It's called PTNS. It's usually offered for overactive bladder, for which it works particularly well, but it's also used for pelvic pain. What is the rationale? There are 2 electrodes, one of which is a needle similar to those used for acupuncture or electromyography. The other one is a surface electrode, a sticky patch, basically. Both are connected to an electrical stimulator. This is a portable model so that the patient can also perform this treatment at home after having been informed and educated by the nurse and after initial sessions in the outpatients, of course. What's the anatomic rationale? We see here that the posterior tibial nerve stimulation follows a pathway. It has an anatomical structure which is perfectly compliant with the positions of the 2 electrodes. It's a nerve which is an afferent of the sciatic nerve, which is directly connected to the sacral roots. So we are actually stimulating the sacral roots downwards in an ascending way. The parameters are the same that nurses use for overactive bladder. So square waveform and these parameters of frequency, duration, and a number of sessions, basically. It can also be done transcutaneously. Initially in the literature, there were some difficulties in accepting the transcutaneous way because the fear of some authors was that not being directly in contact with the nerve or not very close to the nerve, the electrode carrying the current would suffer from dispersion inside the tissues of the leg of the patient. This is not particularly true, or at least it's not true in patients who do not suffer from edema, major obesity, or things like that. And of course, the anatomic rationale stays the same, but with more comfort for the patient who can perform the treatment himself at home. Extracorporeal magnetic innervation, the so-called EXMI. Under the seat, there is a thyroid, which is a circular piece of iron, basically, with a wire, with a copper wire all around. And this is basically an electrical magnet, which parameters can be selected and managed via this machine. So by the law of induction, suggested by Faraday in the 19th century, a conductor immersed in the force lines of an electric of a magnetic field, induces a current. And of course, we are talking about conductors when we talk about muscles and nerves. So muscles can contract and nerves can benefit from the therapeutic effect of the machine. So what's the rationale? This is particularly true for EXMI. I mentioned before the possibility of having a Swiss knife according to the electrical parameters that we choose. EXMI, just like electrical stimulation, can be used for both non-relaxing and non-contracting pelvic floor. So for both pain and urinary incontinence. So these are the suggested stimulation protocols for the non-relaxing, so also for pelvic pain. Okay, but overall, what does the evidence say about all these treatments? Because we are talking about general concepts, but what's the actual evidence about this? Well, this is the most recent systematic review and meta-analysis from the European Association of Urology published in 2020. We can see that this only considers the randomized control trials. There are much more studies, but the trials are only this one. So we are talking about 1, 2, 3, 4, 5, 6 studies actually. So the outcome is the level of pain. So the less, the better, of course. This is a very interesting reduction, a statistically significant reduction of the overall pain scores among the studies, no matter the type of neuromodulation. So this tells us that overall, according to the best evidence that we have, neuromodulation is successful. This is not a meta-analysis. This only provides us with information about what kind of treatment should be used for which kind of problem, which is what exactly we want to know. So here we have the key of all the acronyms. So BPS stands for bladder pain syndrome. CPP for chronic pelvic pain, IC for interstitial cystitis. So for instance, I'm not going through all of this because it would take ages, but interstitial cystitis or bladder pain syndrome would benefit from SNS, which means sacral nerve stimulation, would benefit from percutaneous tibial nerve stimulation, and so on. There are some studies who place some doubts, but overall, I think that the result is very clear and in favor of these treatments. The same applies to the chronic pelvic pain, dysmenorrhea, for which only the TENS has been studied. Pudendal neuralgia, which is a very common and bothersome problem. And we can see that spinal cord stimulation, SCS, has been studied for that. Endometriosis pain, the TENS is very useful, notwithstanding the large confidence intervals, and the provoked vestibulodynia will benefit from TENS. So this is practical information. So overall, summarizing and going towards the conclusions, TENS has been shown to be an effective treatment for women with CPP and dysmenorrhea, and is free from adverse events. It's also cost-effective. PTNS has been shown to be effective in a variety of pain conditions. It's time-consuming because it requires the patient to come to the hospital or to a consultation. Of course, the possibility of doing it transcutaneously and to educate the patient on how to do this treatment on his own at home is a major advantage. More invasive techniques such as spinal cord stimulation require a trial period of stimulation, so these are only reserved to specific and dedicated centers. I'm not going through these tables, but this is only to tell you that in the literature that I am providing you with the slides, you will find these tables, which will basically tell you for each type of problem, what kind of treatment has been done, for how many weeks, with what kind of parameters, the number of hertz, pulse frequency, pulse width, and so on. So you will find all the practical implications if you want to create or update a treatment protocol in your own hospital, in your own reality. Final words, what should nurses be aware of? Diane will discuss this in detail because she will talk about the assessment. The first concept that we should never forget is that the pelvic floor is not a static entity and it's not isolated at all. It's affected by posture, breathing, problems related to obstetrics, gynecology, andrology, neurology, urology, coloproctology, gastroenterology. You mentioned that. We could go on forever, basically, and sometimes other people are involved. So we need the nurses, who are only a part of the team, physiotherapists, urologists, gynecologists, psychologists, midwives for some settings, coloproctologists, diagnosis, and you mentioned that. So this is the first thing that we need to be aware of. Prior to beginning any neuromodulation treatment, careful assessment according to the principle that Diane will provide. And as a result, pelvic floor rehabilitation usually involves several problems at the same time. So it is very unusual that a person presenting with one problem has only that problem. There is very often something else that we need to take into account. So both the assessment and rehabilitation need to consider this. I'm not going through this terminology. Therapeutic relationship is a foundation of rehabilitation, no matter the technique that we use. It can be relaxing exercises, it can be neuromodulation, it can be whatever you want. This is the etymology, just to tell you where this concept, where these words come from. So when we need to talk about compliance, we are expecting the patient to fulfill some kind of expectation. When we talk about adherence, we are talking about staying close to our objectives, our ideal of a program. And therapeutic relationships should go from compliance to concordance, which comes from Latin and means with a heart, actually. So sort of a communion of intention between the rehabilitator and the patient, to adherence, which should be something spontaneous. Without this concept, without these goals, we are going basically nowhere. Take-home messages. The aim of neuromodulation is to intervene on the nervous system to obtain therapeutic effects. This happens through the application of electric currents, invasively or non-invasively. It's almost, well, it's hardly ever the first level treatment, but it's suitable for refractory pain or a second line intervention or an adjuvant intervention. The literature has studied the effect of different neuromodulation strategies, and nurses should be aware of the practical characteristics of this types of neuromodulation, and of how to build a therapeutic relationship based on trust. Thank you very much. And this presentation should serve as an introduction to the following lecture by Dr. Newman. She will tell us about how to assess and properly set up a rehabilitation program of neuromodulation for our patients with chronic pain. Please, Diane.
Thank you very much for asking me to present, and I want to thank the European Association of Urologic Nurses for kindly, giving me this invitation. So I'm going to talk about nursing assessment of patients presenting with pelvic pain. I've been practicing urology for many, many years, and I see men and women daily who present with acute pelvic pain, but also chronic. And I think that all of us listening probably has also been treating these patients and they can be frustrating at times. Here's my conflict of interest. So let's start with the definition. I think the previous speaker had mentioned that chronic pelvic pain is defined as constant or intermittent pain of at least 6 months duration, which occurs below the umbilicus and is severe enough to cause functional disability or require treatment. There are associated conditions, GU conditions with pain as their presenting symptom. And we have the myofascial, which is more skeletal or fascia pain. We have vulvodynia, which is chronic discomfort in the vulva. Many women describe this as burning pain. Vaginismus, which is involuntary tensing or contracting of muscles around the vagina. And sometimes we call this high-tone pelvic floor muscle dysfunction, pelvic floor muscle spasm. We also see in men, particularly prostatitis, which can be a very frustrating problem that we see in urology. And this is painful, difficult urination. Initially, these men may present with bacterial infections, but go on for chronic inflammation of the prostate, as well as chronic pain. And then Congenital Neuralgia is also a condition that usually is caused by some type of trauma. I'm going to go over some of the presenting symptoms of these conditions. What you're seeing and where the research is going in this area is something called urologic chronic pelvic pain syndrome. And this is when the pain is localized to a single organ or site, such as a muscle, or as in bladder pain syndrome, the bladder with urinary symptoms. The most common one that has most of the research, and actually is what we see quite a bit in urology, is something called interstitial cystitis, which has, that terminology has changed to bladder pain syndrome or painful bladder syndrome. And this has really been defined by many organizations that I'm not going to go through, but I have listed them in this slide deck. The International Current Society has defined this. SUFU here in the United States has defined quote unquote bladder pain syndrome, and NIDDK, which is our research arm that has provided most of the funding for this condition, also defines it. The EAU, the Japanese Urology Association, and you can see here ESIC is also defined interstitial cystitis, bladder pain syndrome, as well as the European Urology Association. You can read these on your own, but I think it really just adds the confusion around this condition. When we look at who's most affected by interstitial cystitis, bladder pain syndrome, it's 5 to 1 female to males. I think this is important because this is primarily a female condition. It occurs across the lifespan, but the highest prevalence is in women aged 41 to 45, men 66 to 80. Most are Caucasian. We mostly diagnose in individuals over the age of 30, but I have seen younger patients, and it appears as though the prevalence increases with age. Literally about a month ago, the AUA came out with an updated version of their diagnosis and treatment of interstitial cystitis, bladder pain syndrome. So you can find this online if you Google it. And basically, it tried to update where we are with diagnosis and treatment. And as far as diagnosis, I put this in the slide deck so you can see what they're recommending. And again, it goes back to a careful focus history, physical exam, laboratory examination, and some type of quantifying the voiding symptoms and pain levels. There are many, many different questionnaires out there, and we do have pain questionnaires as far as to determine that. Cystoscopy and urodynamics is really not recommended for the initial assessment. And this is their algorithm. And as you can see, it basically is a focused History, a frequency volume chart to determine how frequent that patient is voiding, because that is a significant symptom that we see with IC bladder pain syndrome. And then as far as only going on to more complex diagnostic tests, if we cannot, after treatment, which is, we just saw here a nice presentation on neuromodulation. I put these other algorithms in this slide set because there are several people also talking about or putting forward how we should be, the pathway down for treatment. And, a lot of it is very similar, but I think you should be aware of this. The one that I found of interest is that this one by this author, Spear, talked about basic testing as far as looking at complete blood count, but I circled this because we cannot rule out sexually transmitted infections. And I don't know what's happening where you are practicing, but in the United States, we're seeing an increase of this. So you have to think about this, that the pain, the symptomatology, GU symptoms may be because of an STI. So you really want to be careful on that. And then also, when do you refer to urology? I find that in my country, in the United States, primary care is not really treating these conditions other than maybe prescribing an antibiotic, and do refer these on to urology or urogynecology. But as you can see by the bottom of this algorithm, as far as for treatment, it really is many specialties, which has been discussed before, that do treat these conditions. So let's talk about chronic pelvic pain conditions. And here's a list of the ones that we see are bowel, myofascial pain, pelvic pain, neuralgias, endometriosis, and vulvodynia. Non-pain conditions that can be chronic, but are non-pelvic conditions. They may be pain conditions, but not in the pelvis, migraines, fibromyalgia, chronic fatigue syndrome, chronic low back pain. But we do see these symptoms in combination with pelvic pain conditions. But up to 20% of patients with chronic pain have more than one pain condition. That's really why these patients are so complex, and they are so disabling to that individual. This is, I think, a nice chart to show you the associated conditions that we see with chronic pelvic pain. And it goes to the span from gynecologic, urologic to neurologic. And I think we have to be aware of this because chronic pelvic pain is really a diagnosis of exclusion. And we have to think about all these other conditions when assessing these patients. So let's talk about a history. You want to start with an open-ended question and literally allow that patient to report to you, to relay to you what exactly they are experiencing, what's most distressing to them, so that your treatment pathways really do address what does most important to the patient. You want to validate that patient's pain experience to develop that trust, as well as these interactions, especially the first visit, are so very important. You're not going to get anywhere with those patients if they don't feel that you believe them and trust what they're saying. Now, you want to do a biopsychosocial pain assessment. And this is a very important part of your examination and your initial assessment. Yeah, you want to do a physical exam, but you want to talk about the burden, what type of occupation they are in. Are they sleeping? Are they fatigued? I suggest that you take the patient history with the patient dress, so you talk to them before you go to that exam, because there is a lot of these patients may have been sexually abused in the past and have trauma, PTSD. So these examinations may be painful. They may not want to have them. So develop that trust with them and that history taking with their one-on-one examination whenever they're dressed. Now let's talk about how you want to screen for that pain. You want to talk about urinary symptoms. We tend to see urinary symptoms such as urgency, frequency, and dysuria. We will see GI symptoms, constipation, diarrhea, bloating, musculoskeletal pain with movement. We may find that someone who is working all day, especially in a very strenuous type of job, may have pain at the end of the day. They tend to report dyspareunia, pain with vaginal intercourse, and really they may become functionally disabled, and also sexually disabled in the sense that they do not want to have any sexual activity. I hear that a lot, especially men who have pain with ejaculation or orgasm. But you do want to talk about past trauma, as in urology, I think we forget about that. but really the data is showing that a lot of individuals with urinary symptoms do have some past trauma in their lives, especially the women. This is an interesting chart, and it's really where we're seeing a lot of the research, and this is called the U-point system. And it was first mentioned by Curtis Nickel up in Canada, and it was recently by Parsons added the sexological component, but it's really the phenotyping. We actually have a lot of NIH research going on in the United States looking at phenotyping of men and women with chronic pelvic pain. And you can see what that assessment should be based on which system that you're thinking about. And the U points go urinary, psychological, as far as organ specific, infectious, neurologic, tender muscle, and then sex difficulty with sexual intimacy. So this U point system is pretty much what we all follow when that guides our assessment. What's important about this slide is the fact that you're going to see more disability and more symptomatology in those who really have moderate or severe pain and urinary symptoms. And you can see how everything's moving here to this pink kind of square here, especially with fatigue, anxiety, pelvic floor muscle tenderness, depression. These individuals are often depressed. So it's something to remember is that the more severe the symptoms, of course, the more you're going to see disability on these different levels. So let's start with interstitial cystitis, the bladder pain syndrome. These symptoms are often described as sensation that someone will report with a UTI without any bacterial infection. In 57% to 98%, we see urinary urgency. The next symptom is daytime frequency, pain, again, suprapubically, perineal, dysuria, referral pain, rectal, genital, abdominal cramps, and dyspareunia. So pain may be anywhere here. They may have nocturia. They may have that sensation of a bladder spasm, which is why a lot of us prescribe anticholinergic or beta-3 adrenergic medication. They'll describe a pubic pressure that is relieved with voiding, and then dyspareunia. The diagnosis is based on the symptomatology. Pain is an essential component of that diagnosis. And it's really important to realize is that pain increases with bladder filling. And the patients will tell you that they void because the pressure and the pain is so intense, and it's relieved by voiding, but only for a short period of time. And then that pain reoccurs. Patients will develop flares that will last several days. And sometimes those flares are around, menstrual cycle in younger women who are still menstruating. They may be triggered by diet. That's a big trigger, which is why these individuals follow a very strict IC diet. And also the other thing we see is that it can be triggered, these flares, by stress. So it's something to remember. I ask them a lot about their jobs and how stressful it may be. I like this slide because it's something as far as differentiating between overactive bladder and UTI. Really, overactive bladder patients do not have pain. They may be uncomfortable with urgency, so they go to the bathroom and they may even rush there, but they do not have pain. With IC, we see pain with no bacteria. And with UTI, we see pain with bacteria in these individuals. That pain will be relieved with treatment. Let's go to vulvodynia. Now, this is a differential diagnosis. And this is sensitivity at the Hart's line, which is in the vulva. And we diagnose that with a cotton tip, and I'll show you that in a minute. It can be generalized or localized as far as the area. What I hear from patients, especially women, is they can't, well, this is only seen in women, that they can't wear tight clothing, jeans or underwear. So they'll lose, they wear loose clothing like sweats or dresses. And they will not have intercourse because any touching of that area is unbearable to them. Vaginismus is a differential diagnosis, and this is really a tight pelvic floor musculature. Like I said before, it may be high tone pelvic floor muscle contraction. So that muscle is always contracted. They do not have intercourse, vaginal penetration, because of the fact that it's so painful. Touch is typically not painful, but pressure in that area. And this condition is really treatable. So it's something to remember, is that this is the one that has most success with treatment. Prostatitis now is what we see in men, and that's pelvic pain at the level of prostate. So it's really in that rectal area. They feel it's similar to a bladder infection, but it's pressure. They'll have frequent urination. We usually have burning with urination. But two of the symptoms I see quite a bit are sexual symptoms. With erections, they have pain, and definitely with orgasm and following intercourse. So that's those are the symptoms that these men will really present with. And it's important to remember that this is inflammation of the prostate without any type of bacterial infection. Congenital neuralgia is also a differential diagnosis. And this is burning pain along the entire pelvic floor and the branch of the pudendal nerve. It's usually not related to bladder function. It may be related to high tone pelvic floor or pudendal nerve compression. It's usually, people call it burning, kind of like electric. It hurts all the time, just not with touch. And a tinal sign, a positive tinal sign, it's just when you put a needle or a pin on the pudendal nerve with touch gently causes that really significant sensation. Now, when you do your assessments, you want to rule out any red flags. Blood in the stool, all right, that should not occur with pelvic pain. Nubile symptoms to start occurring after the age of 50. You want to think about colon cancer, irregular vaginal bleeding over 40, in that woman who is maybe peri or postmenopausal, postcoital bleeding, new pain after menopause, excessive weight loss, pelvic mass, suicidal ideation, or a change in character or severity of the pain over that history of chronic pelvic pain. Now, a pain assessment is really part of this assessment. So you have to determine how you're going to assess for pain. But it's important to understand the pattern. And sometimes I have them do a pain diary that they put down the dates of the pain assessments. They rate it from 0 to 10, with 0 being no pain to 10 being the most severe. Where is it located? I'll show you some body maps I use. Is it associated with, menopause, menstrual cycles, intercourse, and then what medications are they using? Any, whether it be an opioid or just to say a Tylenol, an NSAID. What are they using for the pain? What relieves their pain? What do they do with it? Besides, say, voiding, do they use ice? I have women who put ice on the perineum, that relieves it. We talked about TENS units. So what are they doing to relieve that pain? Now, when we go to physical examination, the goal is to really identify the dermatome, tissues, nerves, muscles, organs that produce that person's pain. So we can try to figure out what's the underlying. So you want to do abdominal and pelvic exam. You want to look at that external genitalia for any pathology, tenderness. You want to look at the skin of the perineum for dermatitis. The ICS report of 2021 is recommending a vaginal and rectal examination. And a digital rectal exam, of course, should be done in men. A rectal exam should be done in men and women, and internal in women. A neurologic examination is also recommended to assess the cutaneous Alodonia along those dermatomes of the abdomen and the perineum. Bulbocavernosa reflex can provide information in men about the intactness of pudendal nerves. And you need to do an MSK exam. I recommend, as a nurse, and I recently did this for a research study, that I was taught the entire MS exam that will be done by a physical therapist, that we're now doing in a research study that we're doing. And I recommend that you really do learn MSK exam, because the muscles surrounding the pelvis may help diagnose the myofascial aspects. And I think that's important prior to maybe referring to a physical therapist, referring on for further treatment. Now, one of the things around pelvic pain is the concept of trigger points. And what are these trigger areas? Well, trigger points are hyperirritable, hard, palpable, localized nodules that are like tight bands of muscles that are painful upon palpation. They can produce local or referred pain when they are compressed or palpated. The pain may be spontaneous or worsened with compression, but they can rise to motor dysfunction. So, actually in gait and on autonomic phenomena. They usually manifest as coccyx or sacral pain in the rectum, perirectal area, vagina, or the low back. This is what I was talking about before, as far as a body pain map. I use this as part of one of my questionnaires. I use the O'Leary Sant, and I ask patients to pinpoint, put X's where they have pain, women and men. And you tend to see pain around the suprapubic perineal area, but you may see referred pain down the thighs. Where do men have the pain? The tip of the penis, or say in the scrotum or in the rectum? And in women, for them to isolate where that pain is. You know, a lot of my women aren't quite sure what the perineum looks like, so I actually have a mirror and I'll show them. And I'll say, well, point to me where your pain is if they can't necessarily point it on this body map. This helps me a lot, especially as I go through treatment, is pain in this specific area is improved and or gone away. And that gives you also an idea of where that trigger point is. Now, Ross has a nice publication where he talks about trigger points and puts markings on the abdomen. You want to palpate all 4 quadrants of the abdomen, but you tend to maybe feel pain in these areas. And you may want to mark and have the patient say, this is where, with deep palpation, this is where the pain was. So you want to slowly do that assessment around the abdomen. Did I miss it? No, okay. Examples of trigger point referral regions. I wanted to provide this to you because I think it gives a little idea about what muscle in the pelvis as well as in the surrounding muscles may be causing pain in different areas. So this kind of can guide you as far as your assessment. The Carnet test is also, I think, another test that you can easily do. This has been written up in many textbooks, and it actually, here's a picture of it. And you can perform this by the patient rising their legs or lifting their head. And then by pressing down in the abdominal wall, does that worsen, reproduce their pain? And this can kind of help you as far as where the trigger point for that pain is and whether this is myofascial pain. So this is also something that should be part of your assessment. The sniff, flop, drop technique, I know Stefano has written about this. And this is really the assessment to determine, again, where that pain may be. You know, I think that it's something that can be part of your, you know, initial assessment of that patient. And it's easy to do. I mean, the patient can be literally sitting on the exam table and do this, and you can walk them through this test. This can really help give you that information as far as exactly where that pain may be located. Now you want to do an external visual assessment of the external perineum, and you want to make sure that you understand what are the structures in the perineum. So I'm going to show you some pictures. You want to look for dryness, ulcerations, bad signs, dark discoloration. I saw someone recently who was really having pain in their labia, and basically it was a labial carcinoma. And she thought someone had thought it was vulvodynia. You do see abnormalities there, and lesions are something you really want to follow up with. External sensory type of assessment, you want to use a cotton tip to determine, you know, brushing that the vulvar vestibule, is that painful? This is very much the case in women who will have vulvodynia, but in patients who have chronic pelvic pain, this may also be something that you want to assess. And this is easy because a cotton tip, do they feel the cotton tip? So the sensory there as far as sensation, and then going along to determine whether they have any pain. A single digit should be done, by the way, when you do an internal, we'll talk about that, but this gives you further idea as far as where the different areas that you can do as far as using the clock, 1, 4, 6, 7, 11 o'clock, as far as touching those areas, and have them rate the pain on a Likert scale, mild, moderate, or severe. Now, you know, myofascial trigger point pain is found in several different areas. So I do with my MSK exam, my musculoskeletal, check the back, have them lean forward, have them lift and do some different maneuvers, as well as in the pelvis, to determine exactly where possibly their pain is centered. Now, pudendal nerve entrapment, this is usually caused by some kind of trauma. I actually had someone who delivered twins who actually developed pudendal nerve entrapment on one side, so it's usually unilateral. It has a burning quality. Sometimes it can be exacerbated by rectal palpation. So when you do your rectal exam, that may trigger the pain, or it may be latent. And this can be tested with some of your urodynamic equipment. This is rare though, but it's something to think about in someone who has chronic pelvic pain. Has this assessment been performed? Now in men, you do see men with chronic pelvic pain. We have a whole research consortium on looking at men. Again, it could be the external genitalia, the urethra. Patients will talk about pain at the tip of the penis, suprapubic tenderness, prostate exam may be painful, as well as a scrotal exam. And I give you this in the slide deck because it's a nice picture of the muscles and what we're looking at as far as where that pain can be from. It may be referred pain from one of these muscle groups, but these muscles are intertwined. They're different in men and women, but it's something we all as nurses need to become familiar with whenever we do this assessment of either a male or female with chronic pelvic pain. I want to share with you now, and I'm going to end this lecture on assessment that we actually have developed for an NIH study that we're doing on prevention of lower urinary tract symptoms. We're looking at women for bladder health across the lifespan. And part of the component is bringing a subset of this population in for an examination. And we're doing 4 components of a pelvic exam, looking at prolapse just with Valsalva, just a grade 4 prolapse. We're looking at tear of the muscle, say that may have occurred with delivery, vaginal delivery. We're looking at the pelvic floor muscle assessment to determine if the patient can identify and isolate and contract the muscle. And then we're doing myofascial examination. So I'll show you some of the training that we've done of nurse practitioners and physicians in this consortium for this research study. What's important when you assess pain in the female patient is the fact, by the way, this research is just in women, is 1 digit. Most of these patients are cringing, do not want a pelvic examination because they feel that might trigger the pain. So you want to be as gentle as possible. So 1 finger, put down into the muscle, tap that muscle, and you want to have the patient, can they feel your finger and have them contract and sustain the contraction. We're doing it midline at the 6 o'clock, and that's why you see a picture here, with the finger pad down in the middle of the muscle, and then we're doing on the right and the left side, 4 o'clock and 8 o'clock. The MAP Research Consortium, which has published quite a bit, and that's the consortium for looking at chronic pelvic pain in men and women, has published this. And I actually use this also in my practice for pain. It's a simple assessment, and basically using the clock with 1 digit intravaginally to determine exactly where the pain is at the 12 o'clock. And you can see that that key for the image as far as telling you what you're feeling, whether the patient at 12 o'clock, that's the meatus, 1 and 11 o'clock is a urogenital diaphragm, and other landmarks here. So this can help you. And I actually have this scanned in, I have this in my electronic medical record for that patient, so I can state where that pain is, and then with follow-up after treatment where that pain has resolved. They've also done one of these for men, and this is the one for men, and this is, of course, is rectally. And you can see using that clock, again, concept, where the anus is, where the prostate is, and exactly feeling as far as where that pain is so that you can really isolate it. And I really suggest you read the article. This is by Yang, and I'll send it to the group here so that you can read it. But this is a really helpful exam, and it's a simpler exam to do. But there's also the pelvic floor myofascial pain exam, and this has been published by Meister and Jerry Lauder out of, they're at WashU in St. Louis. And this is basically to determine myofascial pain doing internal vaginal exam. You first press on the patient's thigh with pressure to tell them how much pressure that you will be exerting in the vagina, and that you're going to ask them to tell you if they have any pain or discomfort on a scale of 0 to 10. And basically, the mid-thigh serves as that reference point for pressure to be applied to determine whether they're going to have pain. And this is kind of our instructions for how you would do this. And basically, with the index finger, the dominant hand, you first do the center of the muscle belly, and then you sweep along. And again, you use that clock. And we actually made this clock to determine the obturator internus here and the levator ani muscle, which you will be pressing on here and here, and that's the right side, and here, similar to what that pressure is you had on the patient's thigh. And the next slide will show you kind of a picture of doing the obturator internus muscle. So you would sweep along here, the top, and then you would sweep down the levator ani, again, with pressure, telling them about 8 to 10 centimeters. Do they feel pain or discomfort, and to rate it for you. And then if you do the levator ani, you would do that down here, but then you would do the next side. So remember, up on top, you do the same side. I do the same side, each side separately. So right top, then I put pressure on the bottom. I'm sorry, I want to show you that. And then I go to the left side of the patient, the top, and then the bottom. So this gives you an idea as far as myofascial pain. We do recommend a UA and CNS depending on whether you think the patient may have also concurrent UTI. Post-for residual to make sure they're emptying, because you do have suprapubic discomfort and pressure. Avoiding diary for someone with interstitial cystitis, bladder pain syndrome can be helpful because you're going to see low volume voids but high frequency. And other pain conditions, I tend not to do them. Urodynamics and cystoscopy are not needed as part of the initial assessment. And that's pretty much standard with all guidelines. And I want to end with this, and I think that Stefano really said this also, is that it really requires a multidisciplinary group to treat chronic pelvic pain. And the dilemma that we have, though, is that these patients go to a lot of specialists, the urologist, the gynecologist, the colorectal. And I think that that's a disservice, because I think unless you treat them together as a pelvis, the GI is there, gynecology is there, urology is there, but it does require really collaboration between these groups, especially as you move forward with treatment. Here are my references, and I thank you very much for inviting me to present this.
Thank you, Diane. Every time I hear your presentations and lectures, I'm always astounded by your deep knowledge of these topics, which are very complicated, but also fascinating from both a scientific and also a humanistic point of view. Okay, I think that we have finished the presentations, so we have a few minutes for the questions from the audience. If the participants have any questions for the lecturers, we are more than happy to answer.
I have one for you, Stefano, if that's okay.
Yes, please.
There is so much, and your presentation was excellent, because there's so much out there on neuromodulation.
Thank you.
And this is a big growth area, isn't it? I mean, there's no question. And the data with chronic pelvic pain is suggestive, but what are you, I'm with you as far as TENS unit. I've used TENS unit with women with interstitial cystitis, and they put it suprapubically. It's been helpful. Have you found one more, just a little bit more, that's been more helpful in your population with all the new types of treatments out there in neuromodulation?
Well, to be honest, where I work, we usually employ TENS with basically surface electrodes. There is one particular thing that I would like to outline, and thank you for this question, because it's very interesting. It's not just a matter of which kind of disease, which kind of type of pain or underlying condition you are treating, because actually there are some types of patients which respond better to a treatment or to another. One of the most important things that I found in my clinical practice is the type of electrode that you use. So for instance, if you apply a vaginal probe or a rectal probe to a patient who has a non-relaxing pelvic floor, this can result in exacerbating the pain and providing and causing spikes of pain, so increasing pain actually. So in these patients, and usually in general in patients to whom I apply the TENS, I prefer to use surface electrodes, at least for the very beginning. So for the males, I usually cut the electrodes because they are this big, so they are 4x4, that they are way too big, of course. So I just cut them with scissors and place them under the perineum. And for women, I do basically the same. I place 2 electrodes on both sides of the vagina, and this greatly helps during the very first sessions. I also find it very useful to associate relaxing exercise with proprioception, so perceiving the effect of being lying on a surface, the breathing, the temperature of the body, and this kind of things, and then the sniff, flop, and drop that you mentioned. So I find the combination of these exercises very useful in the initial part. So even before going to a specific disease or to a specific type of pain, I think that my first attention shall be directed to making the patient feel at home, feel comfortable with what I am doing with his or her body. And this helps a lot. Also, because otherwise, if I increase the pain that the patient already experiences, I'm losing the patient after the first session. So that would make no sense. So thanks, because this is actually a very interesting question.
Yeah, that's really important what you said about the fact that these patients, especially if they have some type of muscle spasm or tightness of the pelvic floor, they don't want anything internally. Yeah. That's sometimes why, even on my first visit with my assessment, listening to them, and if they talk to me about how much discomfort they have, and a lot of the women will go over sexual activity and how they just don't do it anymore, I may put off that exam until a second visit or something. Yeah. Because I want them to get a little more comfortable with me, because you're right, is men I don't have as much of an issue with. I think it's fascinating with men that I just think that chronic pelvic pain that we see between men and women is different, and we don't really understand, right, what is causing it. And I think that we just are really don't have enough research in this area. I think the phenotyping is helping, but I still think we have a long way to go.
Yes, I think that another important question, I think another important aspect is the fact of having the patients presenting with their own partners, because you mentioned the sexual activity, sexual intercourses, which are very, very important. Often patients present by themselves. At least in my experience, it would be important for them to present with their own partner, because one of the first things that pelvic pain impairs is sexual activity, which disrupts the relationship with the partner. So usually I think it's important to tell them to invite their partner to come and to discuss the problem with us, because they are part of the solution, basically. Also, good sex also is not about penetration, it's about relationship, and it also can help relaxing the pelvic floor with proper actions, proper maneuvers. So this might be of help as well.
Thank you. I didn't put that in my presentation, but that's a very, very good point, because you're right what you're saying, and then you also may get a different view from the partner. So I think that's a really good point. So, and maybe if you can't do that with the first visit, maybe say, hey, next time you come, why don't you bring your partner so we can talk about some ways maybe to help you develop that relationship. So great. Right. So I don't think there are questions from the audience. So I think that if nobody has other remarks, we can close the webinar. And there is a question. How can the Playful trigger points be directly treated? That's for you. Yeah, there's a lot of data out there about myofascial kind of manual therapy. And I do recommend a physical therapy consultation if someone I identify with myofascial pain with trigger points. So I think that's one way. But I had to tell you also is that sometimes things like ice on that area, if you can identify the trigger point, really does help. So there are some other things that can be tried. In the United States, physical therapy is a referral from, I have to give that referral. And there's not all insurance covers physical therapy in the United States. So we have a little bit different here. But we do have some good data that manual therapy does work. And more nurses are learning manual therapy, especially with the vaginal therapy, as far as trying to relieve some of those tautness of those trigger points. So that's something to think about. Yeah. There's a question from Gwendolyn.
Hi, Gwen. Welcome. Do you find that non-pharmacologic treatments such heating pads, warm baths, OTC patches are helpful? Yes, some of my patients use them. And of course, it is well known that heat can lead to relaxation, muscular relaxation. It helps with the contractions in other physical districts, such as the shoulders or the neck. So it also works for the pelvic floor. What other self-help therapies would you recommend? Well, I think that everybody has his or her own strategies for relaxing. These are among the most common. I would say that one thing that I usually recommend to my patients is to go home, create a relaxing environment, no matter what they do. They can use candles, perfumes, music, soft lights, whatever, with their partner, alone, with their cats. So also some patients appreciate the presence of animals, pets. They find it relaxing. Okay, and I suggest them to do the relaxing exercises, the breathing exercises. So no matter the method, the important thing is to encourage the patient to do so. There is another question. How do you best manage patient expectations? Sometimes a partial improvement is all we can achieve, but it's a disappointment to them. Diane, what's your opinion on this?
Oh, that is a great question, of which I don't know if I have an answer. This is so true, and this is why, I said before, is that we really need to find out what is the worst symptom the patient's having, when does it happen, and then what do they expect. To say to the patient, well, yeah, this is going to totally cure your pelvic pain. You and I know that's not going to be the case in most of these patients. So you have to really give them realistic expectations. And I find with lower urinary tract symptoms, the ball is always moving. That's why I like things like diaries and body maps to say, okay, well, last time, you noted you had pain here and here, but now you don't have pain here. And they're like, oh, well, that's true. That one went away. So you have to figure out how to be able to monitor that treatment with utilizing some of the tools that we have, because it's always a moving target. And I think diaries can be helpful, but I think also, being frank with the patient and really, what do you expect from this and what can we do? And then monitoring them closely for improvement.
Yeah, sometimes when something does not go in the right direction, the patient immediately sees the worst part of the rehabilitation. So, okay, it's not working anymore. It used to work until last time, but now it's not working anymore. How come? You have been improving for 1 month, 2 months,
Right.
for instance. Now you have a problem, okay, but we can get it sorted, or at least it's just a small part of the whole rehabilitation process and of all the achievements that you have got so far. So this is important.
The other thing to track too for improvement is the flare-ups. That's something to really remember, is that their flare-ups which triggered for whatever, they may find that those are getting less and less. So try to really determine, what's going on with that patient and what is their goal. And I think that, it takes almost like an investigator to really determine that.
I agree. Right. I don't see any other questions. There was an appreciation from Eva. Thank you very much. Glad you appreciated the course. Right. If there are no other remarks, I think we can close this webinar.
Thank you so much.
Thank you very much. It's been my pleasure to be here with you, to be here with Diane and Chiara. And thank you very much to all the participants. We hope that you have enjoyed the course. And of course, we remain at disposal. If you have any other questions, please feel free to send your inquiry to our mailboxes, and we will be more than happy to reply. Thank you very much, and goodbye. Have a good evening if it's evening when you're leaving. Bye. Thank you very much. Goodbye.